Okay, thank you.
Thanks, Julie, and really thank you, Professor Vang, to come talk to us for us today. It's really an honor to introduce you here. A neonatologist from Buenos Aires in Argentina, and did some seminal work in just what I call myth busting, some concepts where you already think about and does it actually make sense? Does it fit with the physiology and the logics behind it? And then some studies showing that no, actually it doesn't. And it changed some key aspects of neonatal practice during my training for sure. So it's a great pleasure to introduce you, Professor Vang. Please, the floor is yours.
Okay, thank you very much. And thank you very much, Julie and Kurt, for the introduction. And it's a pleasure for me to be able to discuss this subject, which is very important for me in my history in neonatology. So I was asked to talk about this meconium aspiration syndrome during around 45 minutes. I'll try to not get you bored during that time. And in the map, you can see the distance from Buenos Aires to Australia, and it's quite far, but we are in the same side of the equator, so it's cold here. I'm sure that there is people that is from the northern hemisphere, and it's having much better weather than at least here in Buenos Aires. So to start on, I have no conflicts of interest to disclose. And the first aspect I want to discuss is that what is the definition of meconium aspiration? And fortunately, there is a very wide range of definitions. We all know that this is respiratory distress in an infant born with meconium stained amniotic fluid. But we have to add that the symptoms cannot be otherwise explained. But what I want to be very strict with this is that there are many descriptions of radiographic findings, but none of them is specific. But what you have to watch in the X-ray is that there are no signs of other diseases responsible for the respiratory distress. So, but the definition is variable. And what is the importance of being variable? Some of them definitions say, well, it has to last for over 24 hours. Others says more than 8 hours. Others says that the infant needs to be on 40% oxygen or more. And
Professor Vang, maybe your slides are not forwarding on the talk. Not sure.
Now, is it now?
Yeah, that's good. Thank you.
Okay, so what I insist is that the X-ray pattern may be different, it has some descriptions, but none of them is specific. And this is very important because having so many definitions, the statistics that you read from any paper that is, let's say, 5% of infants with meconium stained amniotic fluid will have a meconium aspiration. Well, that depends on the definition. If you define it as any respiratory distress lasting for 6 hours, perhaps it's 8 or 10%. So this is very important to understand that there is not a very strict definition, and not everybody talks about the same thing when they talk about meconium aspiration. And I will try to organize my lecture taking each one of these aspects, and I'll start with the epidemiology and incidence. And this is a study coming from Israel in a general population and looking at the frequency of meconium stained amniotic fluid in relationship to gestational age. These are all term infants. But you see that at 37 weeks gestation, 3% of infants have meconium stained amniotic fluid. But if you allow the pregnancy to go on to 41 weeks, then it's 17%. And of course, the incidence of meconium aspiration is related to the incidence of meconium stained amniotic fluid. So it's much higher at the latest part of the term and more so at post-term. And now what we can say also is that we have the incidence of meconium aspiration is very variable because of what I explained with the different definitions. But around 70% of infants who had meconium aspirations were born with a kind of meconium which is thick, like pea soup. And those have a 70%, 70% of the infants with meconium aspiration have this background. Now, if you take all infants born with thick meconium, not all of them will develop meconium aspiration. It's 12%. But if you look at the infants that had only thin meconium, the incidence of meconium aspiration is much lower, around 3%. But another important concept to me is that there is no correlation. If you look at the larynx and try to suction meconium, there is no correlation of how much meconium is found in the trachea to the clinical signs or the severity of meconium aspiration. Now, the other point, which is very important, is that it is more severe when there is suboptimal control of pregnancies and a high incidence of post-term birth. The incidence in the developed countries have decreased, but meconium aspiration continues being a severe disease. In developing countries, it's a substantial problem, but although the incidence is lower in developed countries, the severity is still high. And the mortality, we can say that in high quality NICUs is around 2 to 3% according to some reports, but it may be very high in less developed settings. Now, what's the pathophysiology of the disease? First, meconium can reach the airway in uterus at birth or after birth. And we know that it's associated, I'm not saying caused, but associated, but with fetal distress and hypoxia, but also with fetal maturation, with the appearance of a response to a hormone called motilin, which induces both hypoxia and motilin, the release of meconium. How do I know that it could happen in utero? Well, first of all, autopsies of human infants that were stillbirth have shown the presence of meconium in the alveoli, suggesting that there was some degree of in utero aspiration. And furthermore, there are old studies showing in autopsies of infants who died early in the first 2 days of life from meconium aspiration and pulmonary hypertension that they show vascular changes that could not happen in a minute. They should have taken more than 48 hours to develop. So this suggests strongly that it would happen in utero. Now, there are other aspects that can be considered in the pathophysiology, and that is first that there is inflammation. There is an inflammatory response with increase in the interleukins 6 and 8 and complement activation, etc. So there are signs of inflammation in meconium aspiration. It is known that it happens some surfactant inactivation. That's why some people use a surfactant. We'll go back to this in the last part of the lecture. But also there is obstruction because meconium is in the airway. Now, this is responsible for the different X-ray pictures related to meconium aspiration because some of the obstructions is total and then there is an atelectasis. But some of the obstruction of the airways or the thin airways are partial. So there, it appears that this predisposes to air leaks. And it's also evident in the physiology that there is pulmonary vasoconstriction and remodeling due to intrauterine hypoxia. And this is why many of these infants develop pulmonary hypertension. Now, what are the most important aspects related to pulmonary hypertension? First, there are clinical signs and echocardiographic findings confirming pulmonary hypertension, and many of the infants who develop severe meconium aspiration, you would expect to have an X-ray with a very severe picture, but not all of these infants will have major radiological signs. or major parenchymal injury. Why is that? Because the severity in many cases is more parallel to the severity of pulmonary hypertension than to the amount of meconium that was aspirated. So this is an important component of the high oxygen and ventilator requirements in infants with meconium aspiration. Now, what about surfactant? We know that meconium appears to affect surfactant function. Perhaps the bile salts may inactivate surfactant, and there is also direct toxicity to the type 2 pneumocytes. So maybe there's some displacement of surfactant. So there is a clear inactivation of surfactant. This was studied in several studies, and one important one by Steve Dunn a long time ago. But the information is sufficient to think in surfactant when we are facing a situation with a very difficult infant to manage with meconium aspiration. Now, what about prevention during pregnancy? Well, prevention during pregnancy, there are two possible ways to prevent during pregnancy. I'm not talking about the labor, I'm talking about before labor. And one possibility is that if we know, because you saw that the frequency of meconium stained amniotic fluid is much higher at full term, let's say 41 weeks, or even at post-term, why not inducing delivery at 39 or 40 weeks? Well, there is a meta-analysis of 7 randomized controlled trials with 7,600 patients, and it shows a lower rate of meconium stained amniotic fluid comparing those that were interrupted by induction at 39 or 40 weeks, mostly 39 weeks, but there is no difference in adverse neonatal outcomes. And there is also 100 grams less weight in the infants that were interrupted at 39 to 40 weeks. So there is no positive recommendation of doing this. It's not bad, it's not good. We don't know what's best, because when you deliver voluntarily at 39 weeks, sometimes the dates are wrong and you end delivering an early term or even a late preterm infant. So this is a discussion that has not ended yet. Now, about amnio infusion, I would say that most studies were put together in a Cochrane review that was first published in 2011 and then in 2014. And it shows that with adequate peripartum surveillance, with adequate obstetrics, amnio infusion does not produce any advantage. There are 3 studies that were performed in places with suboptimal perinatal management, and there was a decrease of meconium aspiration and perinatal mortality and other morbidities with amnio infusion. But I have to confess that I really don't think that this is being used for meconium aspiration when meconium stained amniotic fluid is found, or when thick meconium stained amniotic fluid is found. In most of the world, this is not a technique that is being currently in use. Now, what about prevention at birth and the peripartum period? This is something that I was very interested in. And it's interesting because between 1976 and 2005, it was recommended to do a suction of the mouth or nose and nasopharynx or oropharynx before the delivery of the shoulders when there was meconium stained amniotic fluid. And this was based on the idea that if you eliminate from that part of the airway meconium, the infant will have less chances of developing meconium aspiration. Where did this come from? What publications suggested that this was useful? Well, if you look at the paper that was the background, the support for this technique, this is a study by Bonita Carson that was published in 1976. And she compared a treatment group suctioning before the delivery of the chest, suction in the mouth and the nose before the delivery of the chest in infants with meconium stained amniotic fluid, she showed that with no suction, they had 1.9% of meconium aspiration, taking into account all infants with meconium stain amniotic fluid. And in the suction group, they have 0.4%. The P value was 0.071. And following this publication, no other paper in the literature has reported such a low incidence of meconium aspiration among infants born with meconium stain amniotic fluid. However, based on this study, everybody started to do prenatal suction before the delivery of the chest or the shoulders, I would say. And there were two studies a little later than the study by Bonita Carson that show exactly the opposite thing. They were all no randomized control trials that showed the opposite, showed that there was no difference between suction and no suction before the delivery of the shoulders. Still, no way to change this. It went on and on for many, many years. And I would say for almost 30 years. So we decided to do a study, and which was a study that we performed in 11 hospitals in Argentina and 1 hospital in the United States. That was a prospective blind international randomized control trial. Over 2,500 infants with meconium stain amniotic fluid of any consistency in term infants. And we randomized them to suction of the oral and nasopharynx prior to the delivery of the chest, or no suctioning prior to the delivery. And what we found is that there was no difference whatsoever on between the groups. The incidence of meconium aspiration was around 4% in both groups. The need for mechanical ventilation, mortality, duration of oxygen therapy, and duration of mechanical ventilation were exactly the same. So this led to a change in the recommendations by 2005 of the ILCOR, American Academy of Pediatrics, American Heart Association, etc. And in infants born through meconium stain amniotic fluid, suction of the oral and nasopharynx before the delivery of the shoulders was no longer recommended. And there was no increase in the incidence or severity of meconium aspiration following the change in the guidelines. Now, what about the neonatal interventions? Well, and similarly, there was a paper published by Dr. George Gregory, an anesthesiologist that used to work in neonatology in San Francisco for many, many years, and one of the first in describing the use of CPAP in newborns, George Gregory. And they published in the Journal of Pediatrics in 1974 a study, a small study, with 80 meconium stain infants, where to all of them, I'm talking about infants that many were born very vigorous. They were intubated and suctioned, and they compared those 80 infants in a non-randomized control trial to 15 infants that were outborn, and then they had not been suctioned. And the disease was more severe when meconium was found below the vocal cords. Now, Dr. Gregory and his colleagues did not recommend to intubate and suction everybody, but reading this paper, most neonatologists started suctioning all infants with an ET tube, intubation, suctioning all vigorous infants that were born through meconium stain amniotic fluid. And this technique lasted in use from the 70s to the 90s, to the early 90s. Sometime later, in 1989, Dr. Nehama Linder from Israel published a prospective, we call it quasi-randomized study. In reality, what it was is what many of the neonatologists were sure that it was very important to intubate and suction. Other neonatologists thought it was not. So when there was on call a neonatologist that thought that it was good to suction vigorous infants with meconium, they were suctioning, and when the person in charge was not in favor, they did not suction. I know that this is not a good quality study, but they show with over 1,000 patients studied that meconium aspiration was, over 500 infants, they showed that the incidence of meconium aspiration was similar in both groups, and they had some problems, some laryngeal disorders in some of the infants that had been intubated. So their conclusion was that immediate tracheal suction is not harmless and it should be considered superfluous because there were no differences. Motivated by the study by Dr. Linder and Dr. Tom Wiswell organized a prospective large randomized control trial and evaluating in neonatal intubation and suction for all infants born with more than 37 weeks that had meconium stain amniotic fluid of any consistencies. And they included almost 2,100 infants, and they randomized to suction or not to suction. I want to tell you that I know very well Dr. Wiswell, with whom I had worked in some studies, and he was convinced that intubation and suction of meconium stain amniotic fluid infants born vigorously was very important and was useful. What he found was exactly the opposite. They found that no matter if it was thin or thick meconium, the incidence of meconium aspiration was exactly the same with infants that had been intubated and suctioned versus those that had expectant management. And as you know, to intubate a newborn is not an easy task, and to do it in a baby that is crying is very difficult and is, of course, has some additional risk. But I'm an old neonatologist, so I've done it many, many times. We have been doing this for many, many, many years. Unfortunately, somebody came out with such an important large randomized control trial. So this changed the recommendations of ILCOR, et cetera, and other groups. And since then, there was no increase in the incidence of severity of meconium aspiration following the change in the guidelines. In summary, before the year 2015, the major changes in the recommendations to stop supporting previously techniques that were recommended were based on large randomized control trials. Now, what happens when the infants are born with meconium stain amniotic fluid and they are not breathing? Well, the recommendation of the ILCOR until 2010, and I mention ILCOR because many of the other professional associations use similar recommendations. The recommendation said that there is no data to support or refute the use of routine endotracheal suctioning of infants that are born depressed. That means not breathing with meconium stain amniotic fluid. So one can ask, well, what is wrong with intubating and suctioning them? Meconium is in the airway. The baby is not breathing. Why not getting it out? Well, intubating 2 or 3 times and suctioning, like we were doing with the vigorous infants, until there is no more meconium coming, delays positive pressure ventilation and eventually administration of oxygen. So this may be bad, may be good if you eliminate meconium and it does give advantages, but may be also bad. So what happens is that the ILCOR and other associations could not give strong recommendation not having serious randomized control trials. Well, in 2015, there was a publication coming from India where a randomized control trial was done with 122 infants and with a very high incidence of meconium aspiration, 32%, and they were randomized to intubation and suction. I'm talking about depressed infants, non-breathing infants. And they had a very high mortality, but there was no differences in meconium aspiration, severity, complications, or mortality by intubating and suctioning or not doing it. Previously, there was a presentation at the Society for Pediatric Research meeting in 2014 that was only published in 2016 by Sushma Nansha from India also, and they recruited 170 infants or so, And the intubating and suctioning on not doing it did not change the incidence of meconium aspiration and mortality, and there were no differences in other outcomes. Now, based on the first study, the Chetri study, the recommendation changed. We, in an editorial related to the study by Chetri, we took into account both studies and mentioned that to us, it was not sufficient the evidence to recommend no intubation and suction in depressed infants. There were many examples of small studies with an effect that later cannot be sustained after one or more large randomized controlled trials. So the risk of a type 2 error is very high, and we consider that it was not sufficient to give a strong recommendation not to suction depressed infants with meconium stain amniotic fluid. However, ILCOR, and again, based only on the study by Chetri, the first one of the two studies that I just showed, mentioned that there was not sufficient evidence for routine tracheal intubation for suctioning of meconium in non-vigorous infants born with meconium stain amniotic fluid. And this changed the attitude of most of the neonatologists in the world, not all, but many, many people stopped suctioning. Later on, there were two new publications of randomized controlled trials, both also coming from India. So 4 studies, all from India, and where meconium aspiration is a very big problem. So the two studies show that meconium, in one of them, in the first one by Singh, published in 2019, they used a meconium suction device. In all the other studies, in all the other randomized controlled trials, there was no meconium suction device. They were using a direct suction from the wall directly connected to the ET tube. And in all these studies, the people who was attending the deliveries were usually pediatric trainees, pediatric residents, or pediatric trainees. And there was a borderline decrease in meconium aspiration in the group that was suctioned in the first study by Singh, and in the study by Kumar, also published in 2019, with 132 infants, there was no difference in meconium aspiration or mortality. And even there was a trend to worse results in the group that was suctioned. Now, Sushma Nansha also published very recently a Cochrane review of these 4 studies. And she showed that there is no difference in the risk of meconium aspiration suctioning or not suctioning infants who are depressed and are born with meconium stain amniotic fluid. And also the group of ILCOR analyzed the same 4 studies and added an observational study. What is an observational study? An observational study was performed with comparing the population before or after the change in the recommendation of suctioning infants with meconium stain amniotic fluid who were depressed. And in this review, they showed the same thing, that there were no significant difference between infants that were suctioned to those that were not, and they could not exclude any benefit or harm. But what they say, the ILCOR group, what they say is that based on the risk of delaying positive pressure ventilation and the risk of laryngoscopy and tracheal suctioning, the recommendation ended being that not to perform intubation and suctioning of infants that are depressed with meconium stain amniotic fluid. And well, there were several criticisms to this decision. And the first one, and I would say that they are very well reviewed by the Chirivolo and Wiswell in a study, in a paper published in Neo Reviews this year. And they comment in that publication that the operators were trainees, and if you are a trainee and the risk of a potential error in intubating the esophagus, the failure in general, is very high. So how can we know that from the group of intubated and suction infants, all of them were intubated in the trachea and the trachea was suctioned? This is a potential risk when analyzing the studies. There was no use meconium aspirator, a special meconium aspirator. This is something that we can debate if it is important or not important. And it has been shown that in 50% of non-vigorous newborns undergoing suctioning, we can recover meconium, but there is no demonstration that recovering it is better. Nobody has shown that. Now, there are several cohort studies that were recently published comparing before and after the change, and these are also contradictory. And there is a study that was published in 2018, and when you take the infants that were not suctioned and you compare to those that were suctioned, I mean, the period after the change to compare to before the change, when we were still suctioning these infants, well, according to one of the paper published from 4 centers in Texas, the results were worse with no suction, worse. Now, when you look at the study published by the Vermont Oxford Network and was published in 2019, and they showed that there was a lower incidence of meconium aspiration in proportion to the total admissions after the change in the recommendation, but it was a little higher mortality when and a little higher use of surfactant after the change in the recommendation. Now, some aspect better, some aspect worse. And when you look at the results in California, there were better results with no suction. And when you look at the study published more recently in the Journal of Perinatology by Keira, they analyzed in the database in California their own center, and in their own center, the results were better with suction than with no suction. So contradictory to their own study. What I mean is you look at this and you see that cohort studies comparing before and after are not sufficiently good to respond this question. So what is this neonatologist trying to find to decide what to do with his next depressed infant born through meconium stained amniotic fluid? Or what should we all be looking for to answer this question? We are looking for a large multi-center randomized controlled trial. Now, can we perform a large multi-center randomized controlled trial? Well, first of all, we have to ask for consent. Do we have to ask for consent? Can parents under the stress of labor complicated by meconium stained amniotic fluid, can they be competent to consent? Do you think that you really can get an ethically valid informed consent during labor in pregnancy complicated by meconium stained amniotic fluid? To us, the answer to both questions is no. So the only possibility to do this study is with a waiver of informed consent or some strategies that I don't have time to discuss, like the opt-out strategies. Now, let's go to diagnosis and clinical picture. Once again, meconium aspiration is a clinical diagnosis. The clinical picture may range from mild to very severe respiratory distress. The associated pulmonary hypertension is frequently present in the severe cases, and air leaks are not uncommon. Now, these are 2 X-rays from infants with severe meconium aspiration. Are they? Are you sure? Well, if you look at the X-ray on the screen in the right, on the right of the screen, please look, do you find the endotracheal tube? No, and the baby is alive. So you can see that sometimes there is a lot of meconium in the lungs, but without pulmonary hypertension, the baby can become healthy. And in a time when I was a resident, there was a recommendation to get X-rays in all infants with meconium stained amniotic fluid. And there were some infants sucking on the breast, and we went there and took an X-ray because the baby had the background of meconium stain amniotic fluid, and many of the X-rays look like this one. So there is no parallelism in severity and the X-ray findings. Now, what is the treatment of meconium aspiration? Well, there are many aspects. I'm going to go fast through some aspects before you get too tired. General management, like we have any baby in the NICU, looking at the temperature, the management of the fluids, the nutrition. In these cases, some people, when the baby is ventilated, prefers to use sedation because of pulmonary hypertension. We all have to try to avoid the noise. You can imagine a guy like me making rounds is not very good for this infant. So the nurses ask me to speak far away from the incubator and not speak loud. To avoid tactile stimulation, to use frequently when it's necessary, vasoactive drugs, but I'm not gonna get into this in detail. Now, respiratory support is very interesting. First of all, how do we target the oxygen saturations for infants with meconium aspiration? Well, this is unknown. There is a recommendation by the group of Satyan to use a little higher oxygen saturations than those that we use for preterm infants, or at least for small preterm infants. So perhaps limits between 92 and 97 would be a little safer to avoid episodes of hypoxemia that happens with infants with pulmonary hypertension. And we don't want to go to 100% saturation because we don't want to have oxidative stress. So perhaps 92 to 97, but this is not a cooking recipe. I'm just giving you an idea of what is suggested. Now, what are the indications of some kind of assisted ventilation? I can say high oxygen requirement. How high? I don't know. There is no answer for this. CO2 retention, how high? I don't know. And of course, if there appear apnea or air leaks or pulmonary hypertension sufficiently severe, this is an indication for some kind of mechanical ventilation. And the lung physiology is very variable. So we have to be monitoring saturations continuously and when possible, TCP CO2 and respiratory function. Why? Because of the obstruction that variates, and there is meconium that you still keep coming out from the ET tube frequently during a couple of days. So the physiology of the infant changes, and when you are ventilating this infant, you have to be very close to the infant. And what about the use of CPAP? And there is very little number of publications related to CPAP and meconium aspiration. There is only one randomized control trial, also from India, and they show some advantages of CPAP. Very different, the possibility of needing mechanical ventilation when infants were placed on CPAP compared to those that were kept on an oxygen hood or an oxygen cannula. However, when you look at the details, the external validity is very low. Why? Because they excluded all infants with asphyxia, and the patients with APGAR score, the average APGAR score was 7. And the median hospital stay were 4.5 days. So what I mean is these were not very sick infants with meconium stain amniotic fluid and potential meconium aspiration. Those are not the infants that worry us during clinical practice. So I have to confess that I do not recommend in my group the use of CPAP. I don't consider this is too bad, but I hate to see a large infant, 3-kilo infants with meconium stain amniotic fluid fighting against the nasal prongs. Why? Why? Because many of these infants develop air leaks. And if they start crying against the nasal prongs with no known advantage of their use, I don't think that it's a good idea. But I cannot say that this is scientifically right. Now, this neonatologist is asking, well, now I have a baby with meconium aspiration needed 60% FiO2. Should we try high flow nasal cannulas? I don't know. There is only one study of high flow nasal cannulas in meconium aspiration up to July 7 in PubMed. but it was used post-extubation, so it's not very useful for what we are discussing here. Now, what are the indications for mechanical ventilation? Again, they are variable. I would say that more than 50% oxygen perhaps is a good idea, less than 7.25 pH or a higher PCO2 than 60. But again, I don't know if this is too late or too early because there are no randomized control trial. And also the decision of how to ventilate is very difficult because you have areas of the lung that have atelectasis. You would like to use a high PEEP. But if you use a high PEEP and there are other areas that are hyperinflated, then you are not doing the right thing. So it's very difficult to decide. We know that they may need higher tidal volumes and minute ventilation, and perhaps a PEEP of no more than 6. And what is very, very important is to use sufficiently long inspiratory and expiratory times because there is obstruction. So if you use too short times, there is no time for exhalation and there is no time for the pressure that you are using to reach the airway if the inspiratory time is short. So in both cases, we are using low frequency, not very high frequencies with conventional ventilation in meconium aspiration. How about high frequency oscillatory ventilation? High frequency ventilation in general? Well, nobody has demonstrated that it's better, but if you are failing with conventional ventilation, of course you can try high frequency ventilation, but high frequency ventilation may not result very good when the X-ray picture is not homogeneous. So perhaps you have to choose according to the physiology of your particular patient if to try it or not to try it. And there are no randomized control trials discussing possible different settings for these situations. Now, about surfactant, again, there is inactivation of surfactant, so surfactant can be tried. There are several studies that show some improvement, but they are small studies, a total of 326 infants in the Cochrane review by Dr. Dargaville and co-workers, and suggest some advantages. It can be used, according to him, in another publication. It can be used in selected cases, but we should not consider it as a standard of care. And lung lavage has been used in many studies in the old times, and some of them show some advantages, but there is no long-term benefit shown if you take into account all of these studies, and this is a very risky procedure, so I would not recommend it. But I would say that if you have an infant that has a trend to collapsed lungs, and you are not being able to ventilate this infant with meconium aspiration, you can try surfactant, and that's fine. Now, about pulmonary hypertension, I've already mentioned, it's very frequent that we use INO in infants with meconium aspiration and pulmonary hypertension. INO was not specifically designed for meconium aspiration. However, in most of the studies about the use of nitric oxide for PPHN, many of the infants were infants with meconium aspiration and PPHN. So this is a technique that we can use frequently in severe meconium aspiration. I cannot teach you about ECMO. ECMO is very uncommon in Argentina. Very few places perform it. And we know that when an infant is failing, despite the use of whatever the best ventilation you can use and nitric oxide, the ECMO may be indicated. I'm not going to go into details of how do you recommend ECMO, what are the exact situation where you have to be to recommend ECMO, but in the developed world, it's commonly used upon failure of all these things with quite good results. And now about antibiotics. Well, I said that there is inflammation and perhaps infection in infants with meconium stained amniotic fluid. But the Cochrane review has very limited number of studies and very limited number of patients included. And there was no reduction of sepsis and mortality in this Cochrane review from 2017. However, I have to recognize that in my own unit, many of the infants with meconium aspiration will be managed with antibiotics in the first day. Why? Because always I will find a physician that has the excuse to tell me, I have to give him antibiotics because I cannot be sure that this is not a streptococcus pneumonia. So what can I say? Please, if you use antibiotics, stop them after 48 hours if the cultures are negative and the baby does not appear to be septic. And the corticosteroids have also been used, and the risks are there whenever we use corticosteroids. There are some studies that show some advantages, but to tell you the truth, routine use of corticosteroids in meconium aspiration cannot be recommended. There was never a study that showed a benefit in death with the use of corticosteroids. So to end, I would say that many individual therapies have been studied and none have shown to be fantastic to improve these infants or impact on mortality. And the overall mortality rate, however, for meconium aspiration has been declining in the developed countries over the last 40 years. Adequate supportive care and bedside decision-making is very, very important, but how can I quantify how important it is to be there by the baby? And I cannot quantify, but I can recommend it. Infants with severe meconium aspiration and pulmonary hypertension are the sickest, or some of the sickest infants in the NICU, yet they now rarely die in the developed world or in high quality NICUs. And we have to be there by the bedside, at the bedside, and pay attention to the detail. These are not infants that can be managed by twice a day rounds or by inexperienced personnel. So meconium aspiration is not only the result of aspiration of meconium. Perhaps we should change the name of the disease to respiratory distress associated with meconium stained amniotic fluid, but this is too long as a title just as this lecture. Thank you very much.
Thank you, Professor Vane. Maybe you could start your video again. I think I inadvertently turned it off. My apologies. Thank you so much for this overview. This was great. I would invite all the participants to place your questions into the chat, and then we can ask Professor Vane what he thinks about it. Look, I think you provided a perfect overview of something that has, biological plausibility. It is consistent in all the findings that indeed it is an RDS with meconium aspiration stained fluid. I actually don't think the name is too long. I think it's a perfect name for this particular disease. And then the component of the respiratory component versus the pulmonary vascular component can be quite variable in these diseases. So my first question would be, so if this disease is so variable, does a randomized trial make sense, or do you have to subgroup them to get a better answer?
I have no answer for that. I knew that you were going to ask me a difficult question. No, seriously, Kurt, I think that the answer is to do a sufficiently large randomized control trial that will, I'll tell you an anecdotal situation. When we did this study with 2,500 deliveries, and when I saw the details of the weight and the sex, the gender distribution and other aspects, I was surprised to see how equal they were in both groups because of the randomization was well done. I was afraid that people was going to say, oh, this guy just invented the numbers. They are too similar. We had exactly the same number of cesarean sections, the same number of female and male in both groups. And this is the art of using a very large number of patients. So when you estimate the sample size, you have to consider the subgroups, and in that case, it will be sufficiently large to randomize to both with the characteristics of each of one of the patients distributed evenly in both groups. That's the only solution, because if not, it would be very difficult to randomize. I cannot even imagine how will I randomize subgroups within meconium aspiration.
Okay, I can imagine that, because it's so difficult to determine how long they've been exposed in utero, which is the same problem with HIE actually we have. You mentioned some forms of treatments where you said I have a preference for mechanical ventilation over CPAP. Lots of these babies have hyperinflation. Do you think that, is that the reason why you wouldn't prefer CPAP, or?
This is absolutely personal, and I don't have a scientific basis to support what I'm saying, because there are no randomized trials of serious, sufficiently large randomized trials in the acute phase when the infant is placed, let's say, is born, is needing oxygen, is placed on a hood, and then randomized to CPAP or not CPAP, or keeping on a hood. This large study has not been done. And so what I would say is, in my own experience, and this may be related to the quality of nursing or whatever you want, but placing a large infant on nasal prongs, CPAP, and some of these infants are quite alert. If you're talking about perhaps depressed infants that were seriously asphyxiated, I don't know, maybe they will not fight the prongs. So if I put these infants on a ventilator, I may sedate them at least until I get the appropriate settings, and then decrease sedation or just take it out, eliminate it. But if I put them on CPAP, I need them breathing and I cannot sedate them. So many times I've seen pneumothorax associated to using or trying to use CPAP in infants with meconium aspiration, or even in large infants with RDS. Let's say I'm not very in favor of using in a 2,300 infant, 2,300 grams infant with RDS, using CPAP directly. I kind of prefer trying perhaps nasal, high flow nasal cannulas, and avoid high pressures, at least in those infants. For my own experience of pneumothorax, that I think that can be avoided by using a hood and changing from a hood to intubation and surfactant. So, or intubation, surfactant, and extubation, whatever, ensure or whatever technique you use. So it's a concept from the experience that does not have support, but nothing has support. There is no support for CPAP either. So this is what I feel. Perhaps CPAP, if I use CPAP of 4, I don't know how useful I am. If I use 6 or 8, I'm afraid. In ventilation, I use PEEP of 4 in these infants, usually at the start. And then I adapt it to the X-ray picture and the clinical outcome, how the baby is doing.
Now, I've indeed noticed that different places in the world all have their personal sort of approach to ventilatory strategies for different kind of diseases, maybe except for RDS, but certainly in these babies which are a bit more ill. There's a question here from a colleague in Myanmar, which is not uncommon, I guess, in some of the countries here in Asia where they don't have nitric oxide. Do you have any suggestions how they have to treat PPHN if you don't have nitric oxide?
Well, Nitric oxide has been fantastic for those that have the lack of having it. It's extremely expensive yet in Argentina. So many places in Argentina cannot handle it very easily. So I would say that the treatment for pulmonary hypertension, nitric oxide is very good, but it's not the only thing we have to do. I think that it's important to keep these infants quiet, to touch them the least possible, and because frequently they get episodes of hypoxia when touching them or suctioning them. Suction them when you need to suction them, when they get obstructed or you see that there is an episode of hypoxia or noise when you auscultate that deserve suctioning. But again, I would try to keep the lights low, to keep the noise low, and eventually it can be used sildenafil, but I have to say that sildenafil takes a longer time to work. Nitric oxide, as many of us have seen, when you use it and the baby has pulmonary vasoconstriction, is amazing because you get a response immediately. All of us have had the experience of having an infant on 70 or 80% FiO2, and after using nitric oxide, you get the infant rapidly on 30%. Some cases, of course, not everybody responds. But if I don't have it, I wouldn't say that I cannot treat pulmonary hypertension. I can use the other ways of treating it, which mainly is not bothering the infant and trying to keep the infant as well oxygenated as possible. And sometimes you have to use very high settings to get a saturation of over 85, 87%. The problem is that what we used to use in my beginnings for pulmonary hypertension, which is hyperventilation, it has been shown that is not useful and is risky, and other vasodilators such as prostaglandins or derivatives, and they have not demonstrated to be useful, and they are risky because they may bring up hypotension, etc. So I wouldn't recommend those treatments. I would prefer to stay with ventilation, sedation, and not bothering the infant more than what's really, really needed.
Yeah. No, look, optimizing the functional residual capacity in any lung disease will optimize your pulmonary vascular resistance, and you can do the same with indeed sedation. The medications, as you said, nitric oxide works in about 50% of the cases as an instant effect, and some takes a bit more chronic. And all the other medications, they're well studied, but they're variable in their responses, is what I know from the literature from centers who do not have nitric oxide. Here's another interesting question. What's the difference, is a question from Roy, between a term baby with meconium aspiration and, although very less common, a preterm baby with meconium aspiration? Do you think it's different? Is it a different challenge?
Well, it's a good question also. You get the addition of all the challenges from prematurity, but the reality is that I don't know if meconium aspiration does not exist in premature infants, or it is that we don't make the diagnosis or we don't write down the diagnosis. Because if there is meconium and the baby is 34 weeks gestation, and if there was meconium stain and amniotic fluid, why wouldn't we call it meconium aspiration? We tend to call that RDS. But of course, again, if the picture is white out lungs, I would say RDS, but the picture at 34 weeks usually is not white out lungs. So I would tend to say that perhaps there are not that many differences. Perhaps there is at least during the first 1 or 2 days, premature infants tend to not have such an important pulmonary vasoconstriction. So they would have less pulmonary hypertension in the first 2 days or 3 days until they develop muscles in the arteries to produce vasoconstriction when they are ventilated. They can have pulmonary hypertension from the first day, but it's not as common. So there may be clinical differences. I think that what we do is we don't diagnose it. We don't write down that diagnosis when it is a premature infant, but many may fit into all these variable description of the diagnosis of meconium aspiration.
Yeah, it comes back to your title of the paper, RDS with or without meconium stained fluid. I still think it's an excellent description of the disease we're now talking about. Look, it's 1 o'clock, but I have one more question, if I may. So there's a development of lung ultrasound happening in RDS and also a bit of meconium aspiration, not that many studies, since it's one of your topics. Is your team working on lung ultrasound?
And I supervise 3 neonatal units, and I inherited in one of the units a physician trained at the Italian hospital, a lady physician, and she is fantastic at lung ultrasound, and we are all learning. And I have to say that because of my age, I was very skeptic, and I'm trying to suture my lips now because all what I said was wrong. So I would say that with time, I'm quite sure that lung ultrasound will occupy a space, and neonatologists will end learning it, and perhaps it will find a particular space in the neonatal unit. I'm not sure what would that be, but I'm sure that she at least she can describe, or let's say she can have a prognosis of what is happening or how will surfactant work by describing in premature infants, I'm talking now, and why would this not work in meconium aspiration? Probably she would be able, or we, when we learn, will be able to describe how much atelectasis or how much ideated lung can be seen in lung ultrasound. I bet it will become a useful tool in the neonatal unit. It is not yet in my unit because there are few that have already learned some, and only one from the whole staff that can use it clinically with confidence. So my prognosis is that it will be useful.
Oh, okay. Thank you so much. It is past one. Thank you so much for your time, Professor Vane, and for this presentation. We will record, the session is recorded with your permission. We'll put it on the site of the University of Sydney, and I hope we can meet each other at a conference later down the track.
I'm sure we will.
He's looking for an invitation. So he's looking for an invite to Buenos Aires.
And
always.
We will try to find well, we have to first end the economic crisis in Argentina, but then we will organize meetings again, and I'm sure we will get you here. And Australia is also one of my duties to visit you, so sometime I will. And thank you very much again for the invitation.
Thank you. Have a good night. Thanks, everyone. Bye.